Sir, good evening, sir.
Sir, good evening, sir. Can you hear me, sir?
Kamlesh sir, good evening, sir.
Good evening.
Sir.
It is 7 o'clock.
Yes, sir. Yes, sir.
I think Dr. Panda is here. Very good. Dr. Palniappan is here.
Yes, sir.
So I will ask Dr. Panda to say something before we start the teaching. Dr. Panda, please. Dr. Panda.
Sir, actually, sir, am I audible, sir?
Yes, yes.
Am I audible? Yeah. Most respected Professor Dr. Kamlesh Tiwari, sir, and all very senior elite academicians and leaders of APCON, API group, API ICP and PRF group, and my good friend Dr. Palaniappan and Dr. Sanjay, Dr. Amit, Dr. Jayaraman, and then all who are here, along with our promising postgraduates who are there for the short certificate course. I'll tell that with the leadership of Professor Kamlesh Tiwari, sir, our Dean ICP, we have started this new program, and I'm very excited about short certificate course because the postgraduates are learning very long lessons in their curriculum, starting from the symptomatology to the different diseases and systems, and this just a value addition on a specific topic that they can get a clarity on this, and that will not only enhance their understanding, that will give them an opportunity to have a certificate and also take the credit in the long run that they are exposed. And those who like the subject they are taught, they can think of making a career and going ahead in that. So I congratulate the team ICP led by Professor Kamlesh Tiwari, sir. I'm also a member in that, and I also congratulate the whole team. Dr. Palaniappan, Professor Jyotirmay Pal, Dr. Muruganathan, and the whole team of API, ICP, and PRF for continued academic work. And I'm sure this short certificate course will help our young doctors, especially postgraduates, very much. And I'm excited to be part of it with my field, with my subjects very soon. And I'm sure those who have taken this will enjoy the academic. Thank you, the personal touch, and we are there all with you to watch the success of our API, ICP, and PRF. Thank you, everyone. Thank you.
Thank you, sir. Thank you very much. Dr. Palaniappan.
Yes, sir.
Floor is yours. Carry on.
Yes, sir. Good evening, everyone. On behalf of ICP, PG, that's a short certificates course. It's really a wonderful course led by Dr. Kamlesh Tiwari, sir, ICP Dean, under the leadership of President, APA President Dr. Jyotirmay Pal, and PR of Director Dr. Muruganathan. And this short certificate course, definitely it will be useful for a complete physicians, because all short certificate course, not only the physicians from various specialties they are teaching. Nowadays, it's this is also a subspecialty. If you want to practice as a complete physician, you should know all the super specialty subjects also, not completely, at least 75%. So if you want to be a critical care physician, you should know today's topic, that is ABG analysis, because ICU is the bread and butter. In the ICU, whether you are dealing with a metabolic acidosis or alkalosis or respiratory acidosis or alkalosis, depends upon that. The reading, you have to give the medication, as well as you have to treat the ventilator adjustment also, you have to do that. As well as we can find it out the various etiology, and according to that, the root level etiology, you have to treat accordingly. So ABG ABG analysis. It's a very, very, very important for the complete physicians to know. Many things, practical tips. Here we are going to hear from Dr. Jayaraman Srinivasan, I think, and he's a pioneer in ABG management tactics. So we are going to hear a lot of practical tips for the complete physicians. It will be useful not only for the postgraduate students as well as practicing physicians and super specialties peoples also, and critical care medicine people also. So our ICP Dean is doing a lot of works. We are appreciating from our heart. Definitely, it will be useful for the practicing physicians and me too. So over to today's blood gas ABG analysis. Over to Dr. Jayaraman Srinivasan. Yeah. Sir, over to you, sir. Kamlesh Tiwari, sir.
Yes, okay, it's okay. I would like to start the course study now. Dr. Jairam Menon.
Good evening to all of you, and thank you for the opportunity. I hope the slides are visible.
Yeah,
Yes.
Jayaraman, magnify பண்ணுங்களே ஜெயராமன்.
Sir?
கொஞ்சம் magnify பண்ணுங்க, ஷார்ட்டா இருக்கு. Magnify it.
Yeah.
I think F6 small slides. It's visible as a small slide.
Can
You read through it, sir, because I'm doing it on my phone. Can you read through?
Yeah, I can able to read it. If it is coming in a big screen, it
Is
will
it
be
readable?
yeah, readable. Yeah, Jayaraman.
Yeah, good evening, sir. Once again for the opportunity. So today we'll be talking for the next 45 minutes to 1 hour about blood gas analysis. So I work in a corporate hospital in Chennai. And next few slides will be about the introduction, acid-base
So
disorders,
the
primary and
slide is projected partially, what I feel. Only the middle portion is seen, sir. So
Yeah, that's fine. Yeah,
slide
it's
show. It is a
slide, so you can
Yeah,
slide. You can. Yeah, that's fine. But
the format is wrong. This is not in the right format. Have you made slideshow?
Alt F5 माझ्या
Alt T5.
Alt F5
Alt F5. Please press Alt F5 or slideshow.
mobile,
F5.
sir.
In the mobile you are doing. Okay. Mobile also you can magnify. Is it possible, Jayaraman?
So I've done it before.
Mobile is for show. Alt F5.
mobile तो Alt F5 slideshow.
Slideshow will be there in the PowerPoint. That will be full screen. Now the screen is being short. Around 1/3 is occupied.
The technical people, they can help how to do that through mobile.
Yeah. Can you zoom, Jayaraman sir? Can you zoom in the mobile to the full screen?
Yeah.
You zoom it to the full screen in mobile.
Yes, sir.
Not vertical. Put it in landscape. To turn the mobile to landscape.
Landscape.
Yeah.
Turn it landscape. Yeah. The landscape you can do it, not in vertical.
Sorry.
Yeah, fine.
Yeah.
It's fine, Jayaraman.
Yes.
Now decrease the zoom. This is oversized.
Yeah.
Make
Fine.
it,
Yeah, it's fine.
It's fine.
Jayaraman, correct இருக்கு.
Yes.
You can go ahead.
Okay. Next few slides will be about introduction, acid-base disorder, primary and compensatory changes, and interpretation of acid-base disorders in steps, and few case studies. what is acid-base disorder? An acid-base disorder happens in all critically ill patients. Not all need to be corrected. So we are not going to number in ABG. We are going to treat the patients. And treating the cause is important than correcting the ABG. So ABG is a very vast topic, and this 45 minutes to 1 hour, I'll try to cover whatever is possible, because everything about ABG is not possible in this 1 hour. So what is acid-base disorder? Acid-base disorder or pathological changes in partial pressure of carbon dioxide and serum bicarbonate that typically produce abnormal arterial pH. So the body's pH has to be maintained, and two components play important role. One is partial pressure of carbon dioxide, and other one is serum bicarbonate. So acid-base disorders, identifying the underlying cause for the acid-base disorder is more important, and treating the underlying condition, because I keep repeatedly stressing on this in this couple of slides, because we are not going to treat the numbers, we are going to treat the underlying clinical condition, why this acid-base disorder has happened. And this equation is a very important equation for acid-base balance. So it is a reversible equation. That is, carbon dioxide combines with water to form carbonic acid, and this carbonic acid is very unstable as water. So what it does, it breaks into hydrogen ion and bicarbonate. Hydrogen ion, the increase in hydrogen ion decreases the pH. It is reciprocally proportional to pH. So again, when there is more bicarbonate, if you see this equation, carbon dioxide plus water gives you carbonic acid, which again gives hydrogen ion plus bicarbonate. So CO2 is regulated by ventilation. So oxygenation is taking in, breathe. So ventilation is both taking in and carbon dioxide. So carbon dioxide is made of lungs, and the kidney, the work of hydrogen excretion and bicarb generation. So this equation, I'm spending a little more time here because this is the basis for all acid-base disorders. So again, CO2 plus water gives carbonic acid, which in turn gives hydrogen ion plus bicarbonate. So what happens in acidosis is the pH decreases. And what happens in respiratory acidosis? pH decreases, PaCO2 increases. In metabolic acidosis, pH decreases, and the primary problem is bicarbonate here. Bicarbonate also decreases. So you remember a mnemonic ROME. ROME is respiratory is always opposite. Metabolic is equal. So respiratory is opposite. What I mean by opposite is, in respiratory, if it is a primary respiratory problem, when the pH goes down, the opposite happens for PCO2. That is, PCO2 increases. Metabolic, if it is a primary metabolic problem, when the pH goes down, the bicarbonate also goes down. So this mnemonic will give you a clue. So ROME, ROME. Respiratory, opposite happens. Metabolic, it's equivocal. That is, respiratory, pH, if pH goes down, PCO2 goes up. If pH goes up, PCO2 will come down. I'm sorry for this slide, sir. So what happens is few terminologies. Let me get you all oriented. One is, what is acidemia? What is acidosis? Acidemia and alkalemia refers to blood pH. Acidemia is when the pH is less than 7.35. So when you see the pH, you don't say it is acidosis. You call it as acidemia. Alkalemia is when the pH is more than 7.42 or 7.45 as a regular terminology. What is acidosis? Acidosis is the process which leads to acidemia. For example, you say if carbon dioxide builds in the body, you call it as respiratory acidosis. But in the blood, it is reflected as acidemia. So acidosis is the process by which acidemia occurs. Again, alkalosis is the process by which alkalemia occurs. So same thing like anemia, polycythemia, when you see it in the blood picture, the pH, you call it as acidemia, not as acidosis. Acidosis is just the process which leads to acidemia. Again, what is respiratory acidosis? Respiratory acidosis is pH is down and carbon dioxide goes up more than 44 or 45. Metabolic acidosis, the pH goes down and bicarbonate is less than 20 or 22. Alkalosis, there is washout of PCO2. The pH goes up and PCO2 is less than 35. Metabolic alkalosis, again, the bicarb goes up. So some of the conditions where acid-base disturbances happens is complications of acid-base disturbances is cerebral edema. It can lead to seizures. It can lead to decreased myocardial contractility, cardiac arrhythmias, pulmonary vasoconstriction, and systemic vasodilation. If the patient goes in for acidosis, all these complications can occur. So we have to identify the acid-base disturbances as early as possible and treat the underlying condition as early as possible. So respiratory, what will be the, if it is a respiratory acidosis, what will be the primary change? Can anybody just unmute your mic and tell me?
Metabolic alkalosis.
No, respiratory acidosis, what will be the primary change?
CO2
primary
pH
change
will be
will be
down. What will happen to the
rise
PCO2
in CO2.
Primary change will be
PCO2 will rise.
CO2 will be increased.
No, PCO2 will be decreased. No, it will be decreased.
No, no,
Yeah, it will be
no, no, no.
increased.
PCO2 will be increased.
It
Yeah.
will increase in respiratory acidosis.
Carbon
It-
dioxide retention will be there. Yeah.
Yes, there will be carbon dioxide retention, and it is the
Okay,
primary
doctor,
change,
just please unmute your mics.
and compensation will be through the bicarbonate from the kidney. So bicarbonate will compensate for the respiratory bicarbonate may increase and
Again,
may compensate the primary changes in the respiratory acidosis.
So as I told you in the previous slides, always remember the mnemonic Rome. Respiratory is opposite and metabolic is equivocal. So when you talk about respiratory acidosis, the primary changes, when it is acidosis, the pH will be low.
Yeah.
So when it is a primary respiratory acidosis, it is always PCO2 will be on the opposite direction to the pH. So PCO2 will be high. So this is known as hypercarbia. So there is retention of PCO2. So what will be the compensation here?
So bicarbonate.
CO2
So
will
if you
rise.
have just one of you just unmute and tell me, please.
It will be through the
CO2 will increase.
renal compensation of the bicarbonate. Metabolic compensation.
Metabolic alkalosis will be the compensation.
Yes, again. So the compensation will be, the pH will be low, PCO2 will be increasing, and to compensate this, the bicarb will also increase. So if you see the first equation, which I put you on the first bicarb, PCO2 plus oxygen gives carbonic acid, which in turn gives hydrogen and bicarbonate. So once the PCO2 level goes up, what happens? This equation takes place. So more carbonic acid is formed. So again, more hydrogen ions and more bicarbonate is formed. So that's why the compensation happens. The bicarbonate also goes up. Once the PCO2 goes up, the bicarbonate also goes up. So what happens in respiratory alkalosis is, the pH is increasing, so the lungs washout happens. PaCO2
Decrease.
washout. So what happens to the bicarbonate in respiratory alkalosis?
It will decrease for
It decrease.
compensating the respiratory alkalosis.
Yeah, the bicarbonate goes down because again the equation, when there is less amount of PCO2, less amount of carbonic acid and less amount of bicarb. So again that equation plays the role for acid-base balance here. So again for metabolic acidosis, the pH goes down and the bicarbonate also goes down.
Goes down.
And the compensation is PaCO2, there will be washout. Metabolic alkalosis, there will be increase in pH, there will be increase in bicarb. Again, remember the mnemonic, Rome. Only in the respiratory, pH and PCO2 goes in the opposite direction. When it is metabolic, pH and bicarbonate goes in the same direction. So the compensation for metabolic alkalosis is retention of PaCO2. So these are basics of acid base. So there are many steps, approaches to read a ABG. So which I follow, I'm just linked to share with you. This is a 4-step approach. The first step, when you see a ABG, you just identify whether it is acidemia or alkalemia. And the second step, you see whether it is primary is respiratory or metabolic. So if it is respiratory, then you check if it is a chronic respiratory condition or an acute one. If it is a metabolic, then you have to see for the anion gap. These are the 4 steps which I use for reading a ABG. First step is identify whether this is a acidemia or a alkalemic pH. If it is acidemic or alkalemic, what is the primary? Either is a respiratory or a metabolic. If it is a respiratory, acute or chronic. If it is metabolic, check for the anion gap. So when do you call the pH acidemic? When the pH is less than 7.35. When do you call it alkalemic? If it is more than 7.45. So step 2, it is if the primary is disturbance respiratory or metabolic. Respiratory disorder will alter the PaCO2. If you identify this is respiratory is the primary, go to step 3. If you identify if it is a metabolic problem, then go to step 4. So step 3 will be to identify whether it is a acute or a chronic. So there are 2 formulas to see if it is acute or chronic. Just remember these 2 formulas. So pH is equal to 0.008 into PaCO2 minus 40. That is for acute compensation. Chronic 0.003 into PaCO2 minus 40. So this is for checking if it is acute or chronic in respiratory acidosis and respiratory alkalosis. Just remember these 2 formulas. So let's see some of the conditions where respiratory acidosis occurs. So respiratory, when the patient is not breathing well or hypoventilation, there is PaCO2 buildup. So which conditions leads to this PaCO2 buildup? One is CNS depression, like a lot of sedatives used on a patient, or any CNS disease. Lung disease, common disease, or asthma, chronic obstructive lung disease, and musculoskeletal diseases like Guillain-Barré or myasthenia gravis. All these conditions, there will be hypoventilation. The patient will not leave out carbon dioxide. So there will be PaCO2 retention. So some of the conditions where there will be a PaCO2 washout. One is hyperventilation. Nowadays, we see a lot of young people coming with hyperventilation, anxiety disorders. So when you do a ABG on them, you see respiratory alkalosis in these patients. And salicylates poisoning causes respiratory alkalosis. So metabolic acidosis, you check for anion gap. So how is anion gap calculated? Anion gap is positive ions minus the negative ions. So positive ion is sodium minus chloride plus bicarbonate. So usually it is 12 plus or minus 2. So when the anion gap is more than 12, it is known as high anion gap metabolic acidosis. When the anion gap is 12, it is known as non-anion gap metabolic acidosis. So these are some of the conditions of high anion gap acidosis. One is methanol poisoning, uremia, diabetic ketoacidosis, paraldehyde poisoning, lactic acidosis, and poisoning by ethylene glycol or ethanol, and salicylate overdose. All these conditions causes high anion gap metabolic acidosis. And normal anion gap metabolic acidosis, so when the anion gap is 12 or less than that, some of the reasons are GI loss, that is bicarbonate loss in diarrhea, renal losses, renal tubular acidosis, and other conditions. So when there is anion gap, you also measure the delta ratio. I'm just telling you that something like this is there. I don't want to confuse you too much. In metabolic acidosis, a further calculation can be done to see if it is only a high anion gap metabolic acidosis or associated high anion gap. This NAGMA is a non-normal anion gap metabolic acidosis. AGMA is high anion gap metabolic acidosis. So there is something known as delta ratio, which will tell you if there is only high anion gap acidosis or a mixed acidosis, so that you can set your differential diagnosis. If it is a high anion gap metabolic acidosis, you can think of mud piles. Mud piles is the list I had shown you in the previous slide. So let's see a few cases. So this is case number 1. So the pH is 7.24, PCO2 is 60, PO2 is 56 mmHg, and bicarbonate is 24. Can any one of you read this ABG and tell me a bit of
respiratory acidosis. Respiratory acidosis.
Non-compensated respiratory acidosis.
Sir.
It's compensated.
So let's go through the steps. So step 1, is it acidemic or alkalemic?
It's acidemic.
Is it acidemic? So step 2, is it respiratory or metabolic?
Respiratory.
Respiratory.
So why do you think it is respiratory? Because PCO2 is increased. Bicarb is normal.
Yes.
And
remember
pH and PCO2 are going in opposite directions.
Yes.
No,
so
it is not
respiratory is opposite.
compensated.
So pH is down, PCO2 is up. So it is respiratory. So the third step, if it is respiratory, you have to check if it is acute or chronic. So use the formula pH 0.008 into 40 minus 60. 40 is fixed, that is a normal PCO2. 60 is the pH in this, PCO2 in this patient. So it comes around 0.16. So normal pH is 7.4. When you minus 0.16 from this, it correlates with this pH. So we know this is acute respiratory acidosis. So I hope it is clear.
Yes, yes, sir.
Yes, sir.
Very clear, Jayaraman, it's very clear.
Very clear,
Okay.
very clear.
Very clear. Just
I think our
three steps.
students are enjoying.
Enjoying only 3 steps, easy to
Yeah.
handle.
Yes. And only by seeing this pH, PCO2, PO2, and bicarbonate, is it can we identify it as acute or chronic? Can anyone take a guess?
Yeah, yes. Since bicarbonate is in the
Bicarbonate is
normal
normal.
range,
Normal.
so it is not being compensated. So likely to be acute. If
Yes, sir. Very nice. If you remember the equation, what we saw, PCO2 plus water, carbonic acid, again splits into hydrogen ion and bicarbonate. So once the PCO2 is high, we expect, if it is a chronic condition, bicarbonate also to be high. But in this condition, it is normal. So we know this is not a chronic condition. So it is an acute condition. So case 2, it is an 18-year-old with severe diarrhea, diminished urine output, lethargy. Sodium is 135 and chloride is 115. So
The
using
slide
these
is-
4 steps, can any one of you take a try about on this?
Yeah,
AB?
it's metabolic acidosis.
So why do you say it's metabolic acidosis? What's the first step? pH, acidemic or
pH is acidemic.
acidemic? So what do you think is the primary problem here?
Since
Because
PCO2 is near
PCO2 is
normal,
also going down, so it's PCO2 is going down. It's 20 millimeter of mercury, so it is
So
the
that is
primary disorder is metabolic.
PCO2 going down
it is-
correlate with the pH?
PCO2 is near normal. The normal range is 22, something like that. But bicarbonate is 8. So bicarbonate is low and PCO2 is near normal or slightly low. So it is likely to be, it is metabolic acidosis.
Yes, it is metabolic acidosis because PCO2 is not correlating with your pH. pH is acidemic. So for acidemic pH, you want the PCO2 to go up. But
Wow.
here PCO2 is down. So it doesn't correlate with the pH. Next, you go to the bicarb. So bicarb again, pH is down and bicarb is also down. Remember the mnemonic Rome. If it is metabolic is primary, pH and bicarb will be on the same direction. So here both are on the downward direction. So it is a primary metabolic problem. So the first step is identifying whether it's alkalemic or acidemic. So it is acidemic here. And primary disturbance is metabolic because the change in bicarb correlates with the pH. Change in PCO2 doesn't correlate with the pH. So we need not go to the step 3 here because we are dealing with a metabolic problem. Step 3 only if it is a respiratory problem. So we'll skip step 3 and go to step 4. Step 4, you have to identify whether it is a high anion gap or a normal anion gap acidosis. So when we calculate with bicarb, sodium and chloride, the anion gap comes to 12. So it is a metabolic acidosis. Normal anion gap metabolic acidosis. What is the cause? Can anybody give a
Loss of bicarbonate.
So we saw the causes for high anion gap also. We saw the causes for normal anion gap also. So diarrhea is loss of bicarb. So it is a normal anion. It is one of the reasons for normal anion gap metabolic acidosis.
Renal tubular necrosis.
No, in this patient, the severe diarrhea is the reason for loss of
In
bicarbonate.
this patient, yes. Yes.
Yeah.
Loss of bicarbonate from birth.
Yeah. So how many are you going to give bicarb in this patient?
Yes.
So anybody who
I
wants
think-
to give bicarb in this, because bicarb is low. So anybody
Yeah.
who wants to give bicarb?
Bicarb will exacerbate the acidosis.
Yeah. Again,
Acidosis.
what I said in the first few slides, don't treat the numbers, treat the disease. So once you start hydrating this patient, the patient's ABG picture will correct on its own. You hydrate the patient. If there is hypotension, treat hypotension with a lot of fluids. Then the ABG will correct on its own. So that's why I said don't treat the numbers, treat the patient. So case 4.
We manage it. Okay. Diarrhea has to be managed properly, adequately. So
Yeah.
metabolic acidosis will be corrected on its own. Should
On
not
its own,
give
yes.
bicarbonate. Don't treat that's a bicarbonate is low. Don't put bicarbonate. This is the crystal clear message given by Dr. Jayaraman. Fantastic.
Yes.
Yeah. So always all the students should know, don't treat the number, treat the cause. Okay. You can go ahead, Jayaraman.
Yes, this is another example. pH is 7.52. Bicarbonate is 22. PaCO2 is 26.
Respiratory alkalosis.
So why do you say respiratory alkalosis, doctor? Again, step 1. pH is
This is towards alkalosis and PCO2 is low.
Going.
PCO2 is low
Opposite direction.
and it's in the opposite direction.
Opposite direction.
Remember Rome. And bicarbonate is almost normal. So for a normal bicarbonate, you don't expect this pH. The history is a 4-year-old girl with lethargy, irritability, and jaundice. Probably she is hyperventilating because of her disease. So again, step 1, it is alkalemic. Primary disturbance is respiratory. Once it is respiratory, you have to find out whether it is acute or chronic. Then you use the formula. And you use with both 0.008 and 0.003. Whatever comes and correlates with the pH, then you can say it is acute or chronic. Here it is acute respiratory alkalosis. Another clue is the bicarbonate is normal.
Normal.
So you don't expect a chronic change. For a metabolic cause, respiratory compensation happens immediately. But a respiratory cause, metabolic compensation takes hours to days. So it doesn't happen immediately.
Sir, can you repeat this statement? It was very important. I didn't it was a good one. For
Yes,
a respiratory cause,
for example, you say it is a metabolic acidosis. The previous patient with diarrhea, he had metabolic acidosis. The pulmonary compensation happens immediately. The patient will start hyperventilating to wash out the PCO.
Yes, I
But
got it.
if it is a primary respiratory problem, metabolic compensation takes
will take time. Yes, sir.
time, hours.
Thank you so much. Yes, sir. I got it.
Yeah. So this is case 5. pH is 7.14. PCO2 is 70. HCO3 is 26.
Respiratory acidosis.
So what kind of respiratory failure is this?
Respiratory acidosis.
Type 2 respiratory.
Acidemia.
Type 2. Type 2.
It's a type 2 respiratory acidosis. Both hypercarbia and hypoxia is there.
Hypoxia is there. Yeah.
Okay. And coming back to our acid base, we will not go into ventilation. We'll come back to acid base. So step 1, it is, what do you think? Is it acidemic?
Acidemia.
Yeah. So what do you think is the primary problem here?
Respiratory acidosis.
Respiratory.
Respiratory acidosis. Yes. Again, going by the same steps, acidemic, because the PCO2 is very high and it correlates with the pH, we think it is a respiratory problem. And remembering Rome, always pH and respiratory is in the opposite direction. And if it is respiratory, we go in for step 3. So to find out it is acute or chronic. So I have put both the formulas here for acute and chronic. So which one correlates? The
Acute.
pH is 7.14. So the acute formula correlates with that 0.03. If it comes to 0.09, when you from 7.4, if you subtract 0.09, it will not come to this pH. So it is not a chronic one. It is a acute respiratory acidosis. So again, too much of acid base. Let's go in for some medicine also. So how will you treat this patient, type 2 respiratory failure? For example, this patient comes to you with high PCO2 and oxygen is low. So how many of you say A is the treatment? How many of you say B is the treatment?
Treatment.
Reduce the title.
Reduce the
B.
respiratory rate. B.
The respiratory rate and reduce the tidal volume.
Raise A is the treatment.
A.
So I could see a lot of A's coming in. People are typing in A. So yeah, why do you think it is A, doctor? Here we have to wash out the PCO2.
Wash out the CO. Yeah.
So how do you wash out the PCO2 is by
Raising the
Increasing the respiratory rate.
minute ventilation. What is minute ventilation? It is respiratory rate into tidal volume. Either you increase the rate or increase the tidal volume so that there will be PCO2 washout. So am I clear?
Yes, sir.
Sir, if you raise the respiratory rate and the tidal volume, you'll have carbon dioxide buildup, air trapping will be there.
Yes, come again, doctor. Good question. Come again.
Sir, when you increase the respiratory rate and the tidal volume, you'll have air trapping.
Yeah. What doctor is trying to say is, once you increase that rate, so the inspiration will come before the next expiration. So the air trapping will be there. So we have to increase the minute ventilation. If you see there is air trapping, then we have to go and increase the IE ratio, inspiratory expiratory ratio, so that you give more time for expiration. So air trapping doesn't occur. So that is the next step. So again, this is another case. This is a 50-year-old gentleman with abdominal pain, increased urine output, lethargy, sodium 135, chloride is 110, and capillary blood glucose is 600 milligram per deciliter. So what is the first step? It is acidemic. And what is the primary problem here?
Metabolic acidosis.
Metabolic. So we need not go to step 3 because it is a metabolic. We can skip step 3 and go in for step 4. So what is the anion gap in this patient? Can anyone, you have sodium, chloride and bicarb. Can anyone calculate the anion gap and tell me, please?
5.
I think we should correct sodium.
22.
Sodium should be corrected for glucose.
13.
11 it is, I think. 11.
So if it is 11, it is a normal anion gap metabolic acidosis. So with this history, I think this patient is in diabetic ketoacidosis. But if somebody calculates the anion gap and tells me 11, then my diagnosis is wrong. So I heard somebody saying you have to correct the sodium.
Sir, should sodium be corrected for glucose?
So again, this.
Yes, sodium has to be corrected for glucose.
So once glucose increases, the sodium correspondingly will reduce. So you have to, what is given in the lab or ABG, it is a measured sodium. So we have to see what is the corrected sodium. The formula for corrected sodium is 1.6 into glucose minus 100 divided by 100. In this patient, the glucose was 600. So using the formula, when you see the corrected sodium, it comes to 8. So what is the measured sodium is 136. So 136 plus 144, I mean 136 plus 8 is 144. This is the corrected sodium. So if you use this formula and calculate the anion gap, it will come to 22. So now your clinical diagnosis is correlating with your arterial blood gas.
Yes, sir.
So it is a wide anion gap metabolic acidosis. Once you see it is a wide anion gap metabolic acidosis, the list should come to your mind. Mud piles, methanol, uranium, diabetic ketoacidosis, alcoholic ketoacidosis.
Diabetic
So in this
ketoacidosis.
patient, you think about DKA. Treat for DKA. So again, how many of you will give bicarb in this patient? Yes or no? Please type. Let me see
No.
some people typing. Bicarb is 12. How many want to give bicarb? So I see quite a few no's.
No.
So again here, treat the patient condition. DKA, what you have to do is,
Sir, if the patient is in cardiac arrest or something, we will give bicarb. Otherwise, we will not give.
yeah, again, once the tendency, if the bicarb is low, people have the tendency to give bicarb. That's why to say don't treat the number, treat the patient. Adequately hydrate this patient, insulin infusions, and see the potassium and correct the potassium as and when needed. And the bicarb is indicated only if it is pH is less than 7, 50 millimoles. If it is less than 6.3, 100 millimoles. More than 7, if the pH is more than 7, there is no role of bicarb in DKA. So again, no bicarbonate, treat the cause, fluids, insulin, potassium correction, and check for magnesium. So once potassium is down, always magnesium also goes down with potassium. Check magnesium also. And that's how DKA should be corrected. No bicarb unless it is indicated. So someone, can you read this ABG for me, please?
Acidemia.
Yes,
PCO2 is high. It's in opposite
Yes.
direction. So respiratory acidemia.
Respiratory acidosis. Yes.
Okay, respiratory acidemia. Primary problem is respiratory because we use the mnemonic Rome and we know it is in the opposite direction. And if you see the bicarb, it is 36.
It's a rise.
It is.
So can you say with this feature, can you it is acute or chronic?
Yeah. It is chronic.
Chronic it is because there is compensation.
It's chronic.
So there is chronic compensation. Bicarb is 36. It is abnormally high. Using the equation, first equation what we saw, PCO2, there is more PCO2. So it breaks down into more hydrogen ion and more bicarbonate. So there is more bicarbonate in the circulation. This doesn't happen in the acute because as I already told you, metabolic compensation for respiratory doesn't happen in an acute phase. It takes time. So as the case history shows, this is the case of chronic obstructive pulmonary disease.
Kindly repeat the same, Dr. Jayaraman. Actually, it's a respiratory acidemia.
Yes,
respiratory acidemia. So here it's you are telling it's a chronic.
Because the bicarb is high.
High. So it's a chronic.
Yeah.
If it's low means
patients yes, sir.
If it is low, for example, bicarbonate is low means it will be acute.
No, if the bicarb is normal, 20 or 24, it is acute.
Acute. If it is high, it's a chronic. It's a chronic respiratory acidemia.
Yeah, because the compensation for respiratory acidosis is metabolic alkalosis.
Correct.
So bicarbonate is retention.
Sir, just for my clarity, if bicarb is low, then it will be a mixed acidosis, no?
It can be a mixed acidosis. Name one condition where PCO2 will be high and bicarb is low. Where do you see, normally you see this in these kind of patients? This happens in cardiac arrest patients. Once you take a ABG in a cardiac arrest, PCO2 will be high and bicarb will be low. That is mixed acidosis.
Thank you.
Mixed acidosis. Okay. Cardiac arrest. Okay.
Yeah.
Post cardiac arrest, ABG will be like that, sir.
Yeah, PCO2 will be high. The patient is not breathing. And there will be loss of circulation. So there will be a lot of lactates. Let me tell about the next slide, sir. So in this ABG, you see the pH is 7.250. PCO2 is 35. And bicarbonate is 14. So we know it is
Metabolic acid.
Metabolic acidosis.
acidosis. So a patient, 25-year-old male, is coming to my emergency. 2 episodes of generalized tonic-clonic seizures. Now he is in postictal state. So this is this ABG. So what treatment will be giving? He is in metabolic acidosis. Do you need to treat this acidosis?
No, only the cause, treat the cause.
Yes. So in most of the ABGs nowadays, we get lactate levels also. If you see the lactate level in this patient, it is
Very high.
11.5. So why does this seizure patient have acidosis?
Because of lot
Because
of anaerobic
more-
metabolism. So we have to give oxygen and hydration. And
Yes, just treat supportive treatment. You need not treat this ABG. Any seizure patient, the ABG is going to have a metabolic acidosis. You need not treat the metabolic acidosis. Treat the seizure patient. This acidosis will be corrected on its own if the liver function and the kidney functions are normal. Just hydrate these patients and put them on oxygen. So that's why I said treat the patient, don't treat these numbers.
So why does
This
the
will be a
seizure
last
patient
slide.
have metabolic acidosis?
Yes, sir.
Why does seizure have metabolic acidosis?
Why does seizures?
Because
It
of
is,
It
it is a
have
type of
respiratory,
metabolic
no?
acidosis, this is lactic acidosis. Because when the patient is actively convulsing, is not breathing. There's no blood, oxygen supply to the tissues. The tissues go in for anaerobic metabolism from aerobic metabolism. So the lactate is building up, and this causes the acidosis in seizure patients.
Okay.
because of tonic-clonic seizures, it will anaerobic. Aerobic is converted to anaerobic
The oxygen doesn't go to the cells.
cell.
So
So anaerobic metabolism will
metabolism
happen.
becomes anaerobic metabolism. Lactates will build in these patients.
Okay.
Lactic acidosis will cause us the metabolic acidosis. So here you have to treat the GTCS, just giving oxygen and hydration. That's all.
So this is my last case, sir. A 21-year-old woman presents acutely lightheaded and short of breath. She has a final university exam next week. This is a ABG.
It's alkalemia.
Hyperventilation,
Telomerase,
respiratory
Alkalemia,
alkalosis.
PCO2.
Respiratory alkalosis.
So again, don't treat this ABG. Just reassure her.
Yeah.
This ABG will get corrected on itself.
Yes, sir. Panic attack.
So thank you all for your patient listening.
Thanks, sir. It was very nice. Thank you so much.
Welcome.
Is there? Sendil.
Sir,
Yeah, Jayaraman. Fantastic
Jayaraman.
lecture. Lot of good, easy to learn ABG. Now it's very clear. Sendil, you can comment.
Yes, sir. Sir, actually, Jairam has thrown a lot of light on the gray area. So definitely once you start seeing more ABGs, you can understand more, sir. This will be an introduction to ABG. If time permits, in the future, we can have a panel discussion or an interactive case scenario, we can have it, sir. Jairam, very good, Jairam.
And
Thank you,
Sendil, regularly you have to do in the Apicon, you have to do some workshop in the
Yes, sir.
national API. We can, like
Definitely,
in South Zone, South Mid Zone and Tamil Nadu, you have to do lot of workshop to enrich
Definitely.
your
That,
knowledge.
that is a good idea, Palnepan. That is a good idea. It is
Yes, sir.
a
Yes.
very nice class. Most
Yes.
of the students must have grabbed many things. Thank you. Thank you very much.
Thank you, sir.
Yes, sir.
Thank you.
Any questions from the audience? Jayaraman and the Sendil is eager to answer.
Yes, sir.
Any
Sir,
questions?
Yes, sir. Sir, if ABG is compensated, will pH come back to normal always?
So can you repeat the question, please?
Sir, if metabolic acidosis is completely compensated by respiratory, will pH
Yeah.
always come back to normal, or can pH be different?
So it depends on the compensation, sir. If it's a partial compensation, pH will not normalize. If it is a full compensation, it will come to near normal. It may not come to normal.
Sir, so if the pH is not coming back to normal, we can say it is uncompensated, sir.
Partially compensated.
Partially compensated. Okay.
Dr. Jayaraman, impending death, that is pre-death, pre-cardiac arrest, what will be the ABG reports? Pre-cardiac arrest.
If the patient is in hypotension,
For example, one question actually, Jayaraman, actually, patient is having some medication and suddenly allergy, pre-cardiac death, that is pre-cardiac arrest. Pre-cardiac arrest, nowadays the clear, in Tamil Nadu, 2 people died because of inadequate management of the anaphylactic shock. Because nowadays the guideline says pre-cardiac arrest, rightly pointed out by Dr. Sendil Kumaran, immediately give anesthesia of adrenaline, lateral aspect of the gluteal, middle third of the lateral aspect of the gluteal region. And within 3 minutes, the pulse PP will come up. If it is not coming, you can repeat. 2 doses is more than enough, maximum 3 doses. So pre-cardiac arrest stage, if it is arrest, you have to give IV adrenaline. And if it is a pre-cardiac arrest, it is IV adrenaline is contraindicated because it can precipitate arrhythmia. So immediately, even you need not remove the sari or 30 or drowsers. Immediately give the injection 2 ml. So every area, even the injection room, casualty room, everywhere, loaded syringe of cc of adrenaline. Nowadays, I am practicing also. So immediately, if you put, you can revive the patient. Otherwise, that's a permanent damage can occur. So this type of patient, what will be the easy and it's ABG reading, Dr. Jayaraman?
Sir, do we have EpiPen in India?
No EpiPen, ma'am. You can use adrenaline. EpiPen is there, ma'am, but shell life is very, very lesser and it is very expensive. So most of the patients are not afford to buy EpiPen. And most of the time, our patients are they are not known what is a drug causing anaphylaxis for them. So it is always advisable if they know some kind of anaphylaxis is there, then we can advise them on EpiPen. Otherwise, adrenaline is safe.
Adrenaline, IM injection, no IV or subcutaneous. Immediately, even snake bite, ASV allergy also.
Yes.
Immediately, patient can be revived. Okay. One
Sir,
patient, cardiac arrest, and later on, that's various, that's a ventilator, and one patient, Sendil, hello, you can narrate. Hello.
Yes, sir. Yes, sir. The case which you shared, sir.
Yeah.
Actually, this 35-year-old female was evaluated by the gynecologist for EC fatigability and found to have anemia, and the hemoglobin is very low. So the peripheral smear were suggestive of microcytic anemia, suggestive of iron deficiency anemia. So the patient was advised for using iron sucrose. After iron sucrose has been started, it was a small nursing home done by a A&M staff. The staffs are not aware of how to manage any emergency. So suddenly the patient developed difficulty in breathing and rashes and throttling like sensation, choking like sensation, and suddenly went to arrest. Nothing was being done, and then it was shifted to another hospital where she was tried for the resuscitation. But unfortunately, in spite of effective resuscitation, patient could not be revived. and declared dead. So this case is a eye opener that whenever you are starting any kind of iron sucrose or any high allergic drug, the adrenaline should be next to you so that immediate drug can be administered and other catastrophic reactions can be prevented.
So in some of the practices, they give hydrocortisone, hydrocortisone along with such medicines so that this anaphylactic reaction can be avoided. Is it correct or what?
Ma'am,
It's
actually,
absolutely
ma'am,
wrong. It's absolutely wrong. You should not
Yeah.
wait for this. Pre-cardiac
Ma'am,
arrest, no adrenaline, no hydrocortisone, sorry, no avildecatron or efcarlin. Only adrenaline immediately pre-cardiac stage. You will revive. Yes, Sandil.
No, sir. Madam is asking, can we give a pre-medication of hydrocortisone to prevent anaphylactic shock?
Yes, sir.
Ma'am,
Yes, sir.
again,
Exactly that.
again, yes, ma'am. Again, it is the institutional practice, ma'am.
Right.
It depends. There are few centers where they practice hydrocortisone, but still their incidence of anaphylaxis is high.
Okay.
In Sri Lanka, where I had trained in toxicology, where we have 2 units. One unit, they give hydrocortisone, avil, before starting ASV, they will wait for 10 to 15 minutes and then they will start. Then they
Yeah.
will start ASV. There is another unit where they will directly start because there is a 2 school of thought. One, they say that we should not waste the time because the venom goes and bounds the protein and then it will be not being diluted by the or neutralized by the venom. Another one is to prevent the anaphylaxis. But if you carefully see the anaphylaxis due to ASV, it is mainly like a pyrogenic reaction. So this can be prevented by having a clean, sterile hand. And if you put a sterile glove and load the ASV and administer, this kind of reaction can be 100% prevented, ma'am.
Okay, sir. Thank you so much, sir.
Another pre-cardiac arrest patient with the help of gone for a high shock state with the help of ECMO, patient revived after 7 days of ECMO treatment. Another patient. Okay. So proper adrenaline injection in the lateral aspect of gluteal region will save the patient, all pre-cardiac arrest patient. So pre-cardiac arrest patient, don't give avildecatron, efcarlin, don't wait. Give adrenaline off CC. This is a message we want to give to you. Jayaraman, any other comments you want to give?
So you are asking about pre-arrest ABG.
Yeah.
If there is no hypertension, ABG might be normal, sir. If there is hypertension, the patient may have lactic acidosis.
Okay. Yes, sir. Kamlesh Tiwari, sir.
I would like to thank all. Now it is time for Dr. Sanjay Kumar, our Joint Secretary, to give thanks to everybody.
Yes, sir.
Very good evening, sir. It was really a wonderful lecture about the ABG, and not only the students learned, but we also learned the clinical conditions and how to interpret the ABG and what action to be taken. So many thanks, Jayaraman sir, Panaliappam sir, Kamlesh Tiwari sir, Panda sir, and all the participants, students and colleagues for participating in this lecture. So many thanks. I hope it will give a good lesson to the students as well as to us also. So many thanks, Dr. Kamlesh Tiwari sir, for this starting this course and selecting the topics very nicely. Thank you, sir. Thank you to all.
Thank you very much.
Thank you, sir. Thank you. Good night.
Thank you.
Good night, sir.
Thank you, sir.
Really excellent.
Sandil, bye, Sandil. Thank you.